बिस्मिल्लाहिर्रहमानिर्रहीम, अस्सलाम वालेकुम। जाए मत अभी तो बड़ा अच्छा सेशन रहता है। अच्छा, द मोस्ट एंटिसिपेटेड टॉपिक ऑफ दिस डे और द मोस्ट एंटिसिपेटेड सेशन, द बर्निंग इशू नाउ डेज, डायबिटीज़, ओबेसिटी, हर तरफ है। पाकिस्तान नंबर वन पे है, प्रिवेलेंस पे भी। तो दिस इज़ वेरी मच इंटरेस्टिंग डिबेट, और बड़े अच्छे हमारे पास ऑल ओवर द पाकिस्तान कंसल्टेंट्स हैं, चेयरपर्सन्स होंगे। तो प्लीज़ बैठे रहें, ये लास्ट सेशन है, बहुत इंटरेस्टिंग सेशन है। सो स्टार्ट करते हैं सेशन को। फ्यूचर ऑफ डायबिटीज़, फ्यूचर ऑफ डायबिटीज़ रिमिशन। पहले हम डायबिटीज़ को कंट्रोल करने की बात करते थे, और अक्सर सर्जन हमें कहते थे आप लोग क्या करते हैं, सिर्फ कंट्रोल करते हैं। लेकिन अब एक नया वर्ड आया है, रिमिशन। तो फ्यूचर ऑफ डायबिटीज़ रिमिशन क्या होगा? लाइफस्टाइल ओनली, नीडल और स्कैल्पल। तो मैं पहले आप लोगों की क्विक वोटिंग करूंगा। आप लोगों को शो ऑफ हैंड करना होगा। देखेंगे कि कितने लोग जो हैं फेवर करते हैं सिर्फ लाइफस्टाइल मॉडिफिकेशन को। 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14। ठीक है, 14, 15 लोग, फिर हम आखिर में दोबारा एक दफ़ा करेंगे। अच्छा, सेकंड, कौन लोग कहते हैं नीडल इज द फ्यूचर ऑफ डायबिटीज रिमिशन? नीडल मेरा मतलब है GLP-1s, GIPs, ड्यूल ट्रिपल एगोनिस्ट। तो कौन लोग कहते हैं कि वी विल बी नीडल फॉर डायबिटीज रिमिशन? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10। ये आखिर में हमला किया आप लोगों ने, ठीक है। तो मतलब मोर पीपल आर टुवर्ड द लाइफस्टाइल मॉडिफिकेशन एंड अ गुड नंबर इज टुवर्ड द नीडल। नाउ द सर्जन्स फील्ड, कौन कहते हैं स्कैल्पल इज द फ्यूचर ऑफ डायबिटीज रिमिशन? प्लीज शो योर हैंड्स। सर्जन ही उठाएंगे। एक, दो, 3, 4, 5। सो 5, 10, 15। ठीक है, जबरदस्त। अच्छा, ये उसमें मुरवत में उठाया है हाथ, ठीक। हाँ सर, ये जब आपकी कॉन्फ्रेंस होगी ना, फिर हम करेंगे सर दोबारा से। ठीक है, चलिए। अब मैं बुलाता हूँ अपने ओवर दी चेयरपर्सन्स को, वो आ जाए, फिर उसके बाद हम स्पीकर को इंट्रोड्यूस करेंगे। तो फर्स्ट चेयरपर्सन इज प्रोफेसर सईद महर। ही इज अ पास्ट प्रेसिडेंट पेस एंड ही इज द मेन player behind the PES fame and everything. Sir, please join us on the stage. The second chairperson is Professor Dr. Jamshed Khattak. He is a professor of surgery from Hyderabad Medical Complex. Sir, please join us on the stage. And the third chairperson is our president, President PES, Dr. Asghar. Sir, please join us on the stage. सर, वैसे 2/3 मेजोरिटी आप लोग लेके बैठे हुए हैं ऊपर। सर्जन को आपने अकेला किया सर। ठीक है, ठीक है। मैं थोड़ा सा फॉर्मेट समझा दूं। स्पीकर्स के पास 20 मिनट्स होंगे फर्स्ट प्रेजेंटेशन के लिए, तो वो अपने 20 मिनट्स में अपनी प्रेजेंटेशन करेंगे। फिर उसके बाद जब तीनों स्पीकर की प्रेजेंटेशन हो जाएगी तो फिर रिबटल होगा। तो फिर उसके ऊपर आपने कमेंट करना होगा, तो वो 5 to 7 मिनट का होगा। बीच में हम क्वेश्चंस भी लेंगे और एट द एंड हम दोबारा से पोल करेंगे, ताकि हमारे स्पीकर्स ने कितना माइंड मोटिवेट किया है या चेंज किया है। तो ये हम 5, 10 और 15 को दोबारा भी रीअसेस करेंगे। सो विदाउट फर्दर डिले, start with our first speaker of the day, Professor Dr. Ali Jawa. He will be talking about the diet style, lifestyle modification, and please, Dr. Ali Jawa, join us on the stage. Sir, आप तो माइक पहनेंगे ना? ये ले।
Assalamu alaikum. Good Sunday morning. Thank you very much for being here and thank you for staying around. आप जा सकते थे, यकीनी तौर पे एक अच्छा मौसम एंजॉय कर सकते थे। गुफ्तगू का मकसद क्या है कि हम ऐसी चीज़ की बात करें कि जो पायदार है, जो पॉसिबल है, जो हमारे इख्तियार में है, जो हम खुद जिसको अपनी फितरत को आजमाते हुए बेहतर कर सकते हैं। तो दैट्स व्हाट लाइफस्टाइल इज। हमारा लाइफस्टाइल पहले क्या था, अब क्या है, आगे क्या होगा, ये सब हमारी मुट्ठी में है, हमारे इख्तियार में है। इसके बारे में बात करेंगे हम। एक पैराडाइम शिफ्ट आया जो इतनी खामोशी से आया कि शायद हमें पता भी नहीं चला। ये एमा एल्क्विस्ट की स्टडी 2018 में, जिसमें उसने कहा कि आपको ये सोच बदलने की ज़रूरत है। जब हम, या कम से कम मैं जब मेडिकल कॉलेज में था, फ़कत टाइप 1 टाइप 2 दो डायबिटीज़ का जिक्र होता था। वक्त के साथ ये इवॉल्व हुआ। एमा एल्क्विस्ट, स्वीडन का जो ये ग्रुप है जिन्होंने इस चीज़ को प्रोसेस किया, उन्होंने कहा क्या हमें एक मुख्तलिफ तरीके से देखने की ज़रूरत है, हमें एक सोच का अंदाज बदलने की ज़रूरत है कि डायबिटीज़ की अकसाम क्या हैं। तो उन्होंने रिसर्च बेस्ड क्लस्टर्स की गुफ्तगू की। उन्होंने कहा कि 5 क्लस्टर्स हैं जिन पे आप फोकस कर सकते हैं। मुझे ये लगता है कि जब इस नज़र से हम देखेंगे तो लाइफस्टाइल विल मेक मोर सेंस। कुछ चीज़ें मैं कभी भी नहीं कहूँगा कि आप लाइफस्टाइल से कंट्रोल रिमिशन की तरफ लेके जाएं। टाइप 1 कैन नॉट गो इनटू रिमिशन विद टाइप 1। बाकियों में सोचने की ज़रूरत है, क्या उनमें हम ऐसा कर सकते हैं? अगर हम ऐसा कर सकते हैं, क्या हम अपने मरीज को सही इंतखाब कर रहे हैं? क्या सही मरीज के इंतखाब के बाद उसको सही चीज प्रोवाइड कर रहे हैं? दैट इज व्हाट द क्वेश्चन इज। अब डायबिटीज रिमिशन क्या है? A1C लेस देन 6.5 फॉर एटलीस्ट 3 months विदाउट एनी ग्लूकोज लोअरिंग एजेंट्स। सिंपल सी डेफिनेशन। अब अगला सवाल है कि व्हाट रिमिशन इज? Glycemic control without medication, disease activity suppressed. What it's not a eradication. शुगर खत्म नहीं होगी। हमारा मरीज ये सुनने में बहुत इंटरेस्टेड होता है, डॉक्टर साहब क्या मेरी शुगर खत्म हो जाएगी? दैट्स नॉट व्हाट वी क्लेमिंग। वी आर टॉकिंग डायबिटीज रिमिशन and they are listening diabetes eradication. So at some stage you need to clarify in the mind of your patient. What it requires ongoing clinical monitoring, क्योंकि आप ये नहीं कह सकते अब रिमिशन में आ गया भूल जाओ, अब जाके जो मर्जी करो। That's the bad advice. Right patient type 2 में, right within as soon as possible, preferably within the first 6 years of diagnosis, and right action. अब एक चीज जो कि बहुत ज्यादा फैसिनेटिंग जो कि डायरेक्ट ट्रायल में आई। डायरेक्ट ट्रायल वाज कंडक्टेड बाय प्रोफेसर लीन एंड टेलर इन 2017। दैट वाज डन इन यूके। What they did was they demonstrated for diabetes remission you need to have significant weight loss। और ये उनके बारे में जो स्टडी है, उन्होंने ये साबित किया कि पहले साल इफ यू गिव देम अ वेरी लो कैलोरी डाइट ऑफ 850 कैलोरीज, आफ्टर दैट 6 to 8 weeks के बाद आपको नॉर्मल डाइट और कॉन्टिन्यूस मॉनिटरिंग करें, 46% गो इनटू डायबिटीज रिमिशन टाइप 2 डायबिटीज के मरीज इन द फर्स्ट ईयर, 36% रिमेन इन डायबिटीज रिमिशन इन सेकेंड ईयर। पे फॉलोअप स्टडी की है, उन्होंने ये कहा है कि जो लोग अपने इंटरवेंशनल ग्रुप में के स्टाइल पे चलते रहे, 10% रिमेन इन डायबिटीज रिमिशन एंड 5% इन द कंट्रोल ग्रुप। तो ये जो एविडेंस डाई के दैट हैज डेमोन्स्ट्रेटेड गिवन होप दैट यस डायबिटीज रिमिशन इज पॉसिबल, बट द क्वेश्चन इज आर वी गिविंग इट टू द राइट पेशेंट एट द राइट टाइम? एल्क्विस्ट क्लस्टर, ये 5 हैं, बड़े मुश्किल नाम है। मुझे कुछ स्पेनिश, कुछ फ्रेंच और कुछ इंग्लिश के ये एब्रीविएशन से CC मोमा सेड। CC का मतलब है यस यस, मोमा या माँ ने कहा। मैं इस तरह याद करता हूँ। सर्ड सेड मॉड मार्ड सेड। सिवियर इंसुलिन रेजिस्टेंस डायबिटीज, सिवियर इंसुलिन डेफिशिएंट डायबिटीज, mild obesity related diabetes, mild age related diabetes and severe autoimmune disease। अब मैं आपकी समा खराशी करूंगा, सॉरी ये यहाँ पे मुझे बताया गया कि इंटरनेट इज नॉट इफेक्टिव, तो ये मैं मेंटीमीटर नहीं यूज कर पा रहा, बट विल गो दिस वे। 42-year-old अहमद, BMI 34, होमा IR इज 42, ये 4.2 गलती से लिखा गया। A1C 8.1, ट्राइग्लिसराइड 280, ALT हाई है, C पेप्टाइड हाई है, नो एंटीबॉडीज, स्ट्रॉन्ग फैमिली हिस्ट्री ऑफ डायबिटीज, इंसिडेंटली डेथ पर। आपकी नजर में ये कौन से ग्रुप में है? कितने लोग कहते हैं सर्ड, कितने लोग कहते हैं सिड, कितने लोग कहते हैं मॉड मार्ड said. Correct answer is third. Severe insulin-resistant diabetes, high HOMA IR will preserve beta cell function. अब इनमें क्या चीज काम करेगी आपकी नजर में? ये चार चीजें हैं: लाइफस्टाइल, GLP-1, बैरियाट्रिक सर्जरी, नन ऑफ द अबव. कितने लोग कहते हैं लाइफस्टाइल? क्योंकि मैं टॉक लाइफस्टाइल की तरह हूं इसलिए. और कितने लोग कहते हैं GLP-1? कितने कहते हैं बैरियाट्रिक सर्जरी? बैरियाट्रिक सर्जरी. आपको खुश करने के लिए पहला सवाल रखा है मैंने. बैरियाट्रिक सर्जरी. SERD has the highest remission rate post bariatric surgery, 60 to 80% at 2 years. Lifestyle modification alone rarely overcomes severe insulin resistance without substantial sustained weight loss. Now we go to the next case of Fatima. She's 35-year female, lives in Karachi, BMI is 22, A1C 9.4, low fasting C-peptide, GAD antibody is negative, no other autoimmune markers. A, SERD, SID, MARD, SID. Answer is correct. SID. Low C-peptide without autoimmune markers. अब इनमें क्या चीज काम करेगी? लाइफस्टाइल मॉडिफिकेशन, GLP-1 इंजेक्शन, बैरियाट्रिक सर्जरी, none of the above. D, none of the above. SID reflects primary beta cell failure. Without autoimmune destruction or obesity-driven insulin resistance, remission via lifestyle, GLP or surgery is not achievable. Insulin therapy remains the cornerstone. In some cases, trial of perhaps a short-term trial of sulfonylureas would be effective as well. Third case, Bilal, 29-year, Islamabad, is giving a thumbs up because he's happy to be here. A1C 7.2%. HOMA is 20.8, and it gets slightly higher. Normal C-peptide, no autoantibodies. Waist-hip ratio is 1.05, and newly diagnosed as motivated to change. Which one is it? All right. How many say mod? You got it. So obesity-driven insulin resistance will preserve beta cell function. Sorry, सीधा ही आ गया. Sorry, वो slide skip ही हो गई है. तो lifestyle is the answer, and this is the target audience you need to work into. क्योंकि ये वो लोग हैं जिनको lifestyle will help. Highest lifestyle driven remission rate among cluster. Direct trial demonstrated 46% remission at year 1 with structured weight management, 10 to 15 kg weight loss in obesity-related diabetes. Now Hassan, 68-year male, living in Peshawar, BMI is 26. कितने लोग कहते हैं? Mild hypoglycemia? Alright. Yes, it's MARD. Mild age-related diabetes. So which one would work for them? How many say bariatric? It's lifestyle. In MARD, modest weight loss and physical activity improves glycemic control, may induce remission, though rates are lower than MOD. Age-related beta cell decline limits durability, but lifestyle remains the first line. मामूली सा भी lifestyle के अंदर changes आपको बहुत दूर तक लेके जा सकता है. आपको ये भी ध्यान रखना है, एज के साथ बीटा सेल लॉस होता है, उसका आप कुछ नहीं कर सकते. मैंने आखिरी वाले सेट का किया ही नहीं क्योंकि ऑटोइम्यून के अंदर लाइफस्टाइल का रिमिशन में कोई रोल नहीं. इफ यू लुक एट दीज डाटा बेस्ड फ्रॉम द एलक्विस्ट, अगर इन 5 कैटेगरीज की बात करते हैं, तो मॉड एंड मार्ड which are amenable to lifestyle modification constitute 50% of the diabetes population, type 2 diabetes, that is amenable to treatment. If you look at जो burden है इन पाकिस्तान के जो IDF एटलस के मुताबिक वो है 34.5 मिलियन लोग हैं. अगर आप इनको देखें कि मॉड के अगर 11.5 हैं, क्योंकि आपको पता है 35% है, 15% मार्ड के हैं 5 मिलियन, तो दिस 16.5 मिलियन लोग हैं विद डायबिटीज पाकिस्तान दैट कैन पोटेंशियली अचीव डायबिटीज रिमिशन. अब ये उसके फर्दर ब्रेकडाउन है और ये 16.5 है, तो टोटल एस्टिमेटेड लोग, अगर आप अगर याद करिए कि जो आपके पास मॉड के हैं वो अप टू 46% रिमिशन अचीव कर सकते हैं, और जो मार्ड हैं वो उसका 50% 20%। तो अगर आप इस चीज़ को जहन में रखें कि इतने लोग हैं जिनमें लाइफस्टाइल में चेंज आ सकता है, और आप इनके अंदर ये लाइफस्टाइल है, तो आप 6.4 मिलियन लोग की ज़िंदगी बदल सकते हैं, डायबिटीज़ रिमिशन में जा सकते हैं। 64 लाख लोग पाकिस्तान के, अगर हमारे मुताबिक जो है, अगर हम इन पे काम करें तो वी विल बी एबल टू टेक देम टू डायबिटीज रिमिशन। और मेरी टॉक जल्दी खत्म होती है। सिर्फ इस बात से आपको ये सोचने की जरूरत है कि आप जिस कस्टमर की बात कर रहे हैं, जिस मरीज की बात कर रहे हैं, जिस शख्स के जिक्र कर रहे हैं, क्या वो आपका दुरुस्त कैंडिडेट है भी कि नहीं। अगर वो हैं तो क्या आप उनके साथ जस्टिस कर रहे हैं कि अगर आप उनको लाइफस्टाइल ऑफर नहीं करते। लाइफस्टाइल मॉडिफिकेशन के लिए क्या चाहिए, बहुत ज़्यादा क्लोज फॉलोअप चाहिए। मरीज आपको बात करने के पैसे नहीं देता, नुस्खा लिखने के देता है। हमारा जो स्ट्रक्चर है, हमारा जो हेल्थ केयर का है, दैट स्क्यूअर्स टू ट्रीटमेंट। मे बी इट इज द वे दैट वी वर ट्रेन्ड एज डॉक्टर्स। वी वर टोल्ड 3 लाइन्स। लाइफस्टाइल मॉडिफिकेशन सीधा फार्माकोलॉजिकल थेरेपी पे जाते थे। हाउ ऑफन यू हैव एन इक्वल वेटेज ऑन लाइफस्टाइल इन आवर करिकुलम? How often do we talk about lifestyle in our talks here? How often does the lifestyle की काउंसलिंग के लिए हमारे पास टाइम है? स्किल्स, नॉलेज और स्किल्स, इन सब चीज़ों के लिए सबसे पहले इंपॉर्टेंट होता है, कोई भी चीज चेंज लाने के लिए 3 डोमेन्स होती हैं। इफ यू डोंट हैव नॉलेज, गेट नॉलेज। इफ यू डोंट हैव स्किल्स, गैदर द स्किल्स एंड देन चेंज योर एटीट्यूड। ट्रस्ट मी, नॉलेज और स्किल्स का मसला नहीं है, एटीट्यूड टूवर्ड्स लाइफस्टाइल, एटीट्यूड टूवर्ड हेल्थ इज द मेजर इशू। हमें क्या सोचना है एज अ क्लिनिशियन, कैन वी कीप ऑन फायर फाइटिंग or should we prevent a fire? Should we keep on prescribing medication for those who could potentially benefit from our time, effort, skills and knowledge? Or we just let it go, कोई बात नहीं, दवाई लिख दी, ये लेके आओ, 3 महीने बाद आ जा। 64 लाख पोटेंशियल पीपल हैं जिनकी ज़िंदगी आप बदल सकते हैं विदाउट मेडिसिन, विदाउट सर्जरी। मैं आपको ये नहीं कह रहा कि आप उन लोगों को जिनको सर्जरी की ज़रूरत है उनको डिनाई करें। मैं ये नहीं कह रहा कि कुछ लोग हैं जो लाइफस्टाइल को फॉलो नहीं कर पा सकते, आप उनको मेडिकेशन डिनाई करें, लेकिन एफर्ट तो करें, कोशिश तो करें। क्या हम इसके लिए रेडी हैं? क्या इस चैलेंज के लिए कंट्री रेडी है? क्या इस चैलेंज के लिए हमारे पॉलिसी मेकर्स रेडी हैं? क्या हमारा इंफ्रास्ट्रक्चर है? क्या इन 64 लाख लोगों को बात करने के लिए हमारे पास इनफ लोग हैं? अगर डॉक्टर्स के साथ हेल्थ केयर प्रोफेशनल्स हैं, क्या आपको गवर्नमेंट की सपोर्ट है? फ्री दवाई लेना आसान है, बात करने के लिए किसी बंदे को हायर करने का कहना गवर्नमेंट शायद ना माने। क्या हम इस एडवोकेसी और पॉलिसी चेंज के लिए रेडी हैं? क्या ये हमारी सोसाइटी का फ़र्ज़ है? क्या हमारा फ़र्ज़ है? पाकिस्तान एंडोक्राइन सोसाइटी का फ़र्ज़ है? लेट्स थिंक अबाउट इट। एंड बेसिकली रिमिशन डजंट मीन क्योर और रिवर्सल through lifestyle is potentially achievable. At least 20% of diabetes population can benefit from us. We just have to screen for the right person, subclassify, and shift to proactive metabolic health, not reactive health. Sugar ho gayi, it's not a death sentence. Do what you can for yourself, for the world, and for the society. Thank you.
थैंक यू सो मच डॉक्टर अली जावा, इट वाज अ ब्यूटीफुल प्रेजेंटेशन। 64 लाख लोग, ये 64 लाख लोग वो हैं जिनको हम लोग एक्सेस कर सकते हैं, और दवाई माइक, ये 64 लाख लोग वो हैं जिनको हम एक्सेस कर सकते हैं और बग़ैर दवाई लिखे हम उनसे बात कर सकते हैं। Very beautiful. Now the next speaker is Dr. Professor Saeed Abbas Raza, and he's the past president PES also, and he's currently the president of ICE. Sir, please welcome on the stage, and he will be talking about the needles, the medications.
Thank you, Ali. Is my mic on? Thank you, Ali, for presenting for me. Because I'm sandwiched between 16 votes and 22 votes, and I had only 5 votes to present. So I'm starting already been sandwiched between two giants. So let me try to prove what I need to prove, or what Ali has already proved. Thank you for proving my point in saying 40 करोड़ लोगों की जिंदगी बेहतर हो सकती है, 40 करोड़ लोग रिक्योर में जा सकते हैं, 40 करोड़ लोग आपका परफेक्ट लाइफ होता है अगर वो लाइफस्टाइल से चेंज करें. इज इट पॉसिबल? मैं आपको कहता हूं कि इस वक्त सबसे सस्ता प्लॉट चांद के ऊपर है. वुड यू बाय दैट? We need to talk about today, and I think that's very important. Sometimes we tend to forget which is practical approach, which is theoretical approach, which is more aggressive control. Tonsillitis, which is the best treatment? Prevention and doing gargles, taking an antibiotic, or having a tonsillectomy? Which one you would choose if you had the problem? Thank you. Because the concept is not what is an ideal situation, but what the ground reality is. Is injectable better than oral? Yes. Would you prefer oral over the injectables? Yes. So we need to be more clear in it. What is the most expensive treatment? Surgery, medical, or lifestyle? In any clinical trial, which is the most expensive treatment for obesity? Most expensive. Most expensive is lifestyle. All these studies have shown the most expensive treatment is, and again, people come to me and I always guess, मुझे हमेशा इधर अंडे पड़ते हैं. इस जुमले के बाद मैं 4 दफा प्रेजेंट कर चुका हूँ, मुझे 4 दफा अंडे पड़े हैं. ये कह सकते हैं आप स्टेयर्स के ऊपर नहीं जा सकते, ये कौन सा एक्सपेंसिव है? भाई साहब, सिर्फ स्टेयर्स से ऊपर जाने के लिए लाइफस्टाइल चेंज नहीं है. लाइफस्टाइल चेंज इज ईटिंग एन ऑर्गेनिक एग. 1.5 रुपए का देसी अंडा मिलता है, 40 रुपए का देसी अंडा, वो शेवर का अंडा मिलता है, 40 रुपए का देसी अंडा मिलता है. But the price difference is so. Then you need to go to a gym every day. I'm not saying lifestyle is not important. What I'm saying is sometimes lifestyle alone is not possible for most of us. I always, during this presentation, I come across one person raising his hand. You know what? I have lost 20 kgs and I'm maintaining it. And I'm so happy to see that person. Because in an audience of 300 people, there's always one. The rest of them are sitting and say, यार हमें भी करना चाहिए यार, very good, very good, this is good, अगले साल करेंगे. So I think we need to realize what the ground reality is, and we need to realize what, I'm not here to debate that lifestyle is not good, and honestly I'm not here to debate the surgery is not an option. You need to choose what you would choose for your life, what you would want to do. Why do I'm sorry if I'm disclosing this. Why do most of the endocrinologists use injectables to lose weight? Not the surgery, not. If lifestyle is the best way to go, why wouldn't you just, all of us endocrinologists, most of us, some of us are endocrinologists, why wouldn't all of us go for the surgery? Why wouldn't all of us go for the lifestyle? If you ask in privacy, everyone is using injectables. कोई सैंपल आता है ना, ट्राई करके देखते हैं यार, let's try, कोई काम कर जाएगा. So my presentation is almost over now. So the next 16 minutes, but I'm going to show you some of the data that I have to prove it to you, that again we need to realize, and again most of it again is different. And I'm not going to talk about the future. I'm not going to talk about the islet cell with the needle and then curing, because we are still about 20 years behind in as far as the nature of treatment in Pakistan is concerned for most of the things. Now we're catching up thanks to the generics, that we have the latest and cutting edge, which we don't have in the real world. So again, Arshad is here. No, Arshad usually sends me an exciting picture from real life all the way, because I usually like presenting. He sent me this picture because each time I was asked, what is remission, how the remission again, and he just sent me this, and he said, बार बार हॉर्न देकर ना छेड़ें, मैं बच्चों वाली हूँ, the school bus is saying that. So I think we need to also say what is remission and how many times you would be asked what a remission is, how many times you would need to know what a remission is. And Ali nicely pointed out there's partial remission and there's an complete remission, which tells you how long your A1C has been, for how long. If your A1C is 6.5 or less for 3 months, of your partial remission. If you have absolute remission, probably you need to have an A1C which is completely normal for some time. How long can you last it? That's a big question. And I think that is very important for us. The objective is just to go over some of the topics as far as needles and treatments are concerned. And as I was telling you, I'm not going to talk about what's coming in future and what has happened in the past. Lifestyle is wonderful. Every one of us does. That everyone's doing it, I'm not sure. So we'll need to find out. So what are we dealing with in Pakistan? And again, Ali nicely showed this class. We need to know that how many of us has insulin deficiency, how many are antibodies positive. So obviously, these are not the people that you would want to treat, and these are not the people who would want to say. I would like to remind you all on what you call twin cell hypothesis. Again, about good 6 years ago, this data was published, and most of us know. So I'm not here to remind what happened in, but the gist of the information. See, when you start accumulating fat, you accumulate fat in the skin. From skin, it goes to the viscera. From viscera, it goes to the pancreas. In this study, they looked at people who would lose 15 kgs of the weight, how the fat will go away, and they did MRIs to look at it, how the fat will first go away from this, from generalized viscera, from the liver, then from the kidney, how 9 out of 10 people were cured from diabetes, and how 1/3 of the people remained diabetes free if they maintain their weight. So please remember, there's two things: losing weight and maintaining that lost weight. Because even in this study, once they gained weight, it came under the skin, it came under the liver, it came in the liver and went into the pancreas, and you again became diabetic. So it's a vicious cycle. So you need to know how you would want to take. So my question to all of you is, how many kilos of weight do you need to lose to have a diabetes remission? 5 to 10, 10 to 5, 5 to 15. So again, if you look at most of the studies, in this twin study, they looked at 15 kilogram weight, which is actually not what I'm looking for. If you look at its journal, and again, this is something you all of us seen. If you're looking at the improvement, it's 5 or less. And if you look at the diabetes remission, you're looking at 15K. So I would want to hold at this time, at 12 minutes time, I would want everyone to now focus on approximate 15%. So if everyone is aware that 15% is the goal that we need to achieve if we want to get to remission, I think that's the job of how to treat is done. How to achieve it? And I think how many of we use the term NUSH therapies. The NUSH therapy is actually a nutrient stimulated hormone therapy. Anything which is stimulates by the gut, by the hormones. And I think at this time and age, this is the focus of how you are. This is debate. I'm not going to go to detail which hormone is secreted by which are the enteroendocrine hormones, what are the endopancreatic hormones. But remember, these are the GLP-1s, GIPs, MLN. These are all hormones which are being secreted through the gut, through the stimulus of the food, which helps us maintain our food intake and whatnot. So that's something. And again, liraglutide, semaglutide are the options. I remember working with the Gets about 8 years ago, and we were trying to publish metabicity as the standard of care for Pakistan. And again, most of my colleagues have been part of metabicity guidelines. We came out, and this is what we said with the different BMI that you need to treat and how you would want to proceed as far as treatment. And the reason for it, metabolic disorders, obesity, diabetes. Not everyone fall into category, but the majority of the people fall into this category. And I think that's something that we need to take into account. This is just a summary of how different treatments for it. So now next 5 to 10 minutes, I'm going to focus on obesity. Because if we take the concept of surgery, lifestyle modification or medication, I'm pretty sure you would realize that the gist is weight loss. So let's talk about the weight loss. Somehow it's clicking 2 slides. I'm sorry, it's supposed to. So, all right. So again, you work in the center and you work through the GLP-1s. Unfortunately, we sometimes tend to forget. And again, during the meeting, there's all about GLP-1s injectables, but there's no talk about the orals. And this slide was showing that, but let me just put the anti-obesity oral medication which are out there. They work starting from 5 to 8% to 7 to 10%, 5 to 6%. These medication work. But what do you notice here? Side effects. What else do you notice here? Huh? Thank you. Thank you. So at least 2 people knew what I was talking about. We're not reaching the 15% ballpark number that we're achieving. What are we missing here? So we talked about the phentermine, topiramate, and buprenorphine and nextron. What are we missing as far as hair is concerned? Thank you. Omar? So Omar made this slide, so I'm just presenting it for Omar. Thank you, Omar. Because exactly, we're missing out on the oral GLP-1s. And again, if you look at it, the 2 big oral GLPs, semaglutide, and people who don't know about orforglipron, fasten your seat belts, get ready for a ride. In about 3 months' time, you'll get brochures all over. This oral GLP-1 is coming. It's a non-peptide. It's coming out. You will hear all about it. If you don't know about it now, please know. Because this is FDA approved. It's coming out. It's going to be because it's oral. And again, coming back to the same concept that I was saying. Injectables are wonderful. But you would prefer oral. If it comes down to the problem of it. So in studies, I'll show you some of the data. They are comparable. Oral semaglutide has come up with extended formulation for weight loss, which is 25 milligram, which cause more weight gain than what's mentioned here. But if you look at the general ballpark, they do cause weight loss. But what are they not achieving? 15%. So next time when you vote, think of 15% at the end of the debate. This is the comparison between the semaglutide and Orfor. And I think one thing I don't want to go. So this is about 12 milligram. This is 12 milligram. This is 36 milligram. And the doses of semaglutide as well. But one thing that you need to learn, they didn't market it at the same dose. And I'll come to that later on. It's very interesting. They did studies with a different stat and then they marketed it on a different way. So if you look at it, the one point that I would all of you to monitor is about 23% in a very high dose of Orfor were able to lose what? Thank you. So again, people did lose weight. And again, when you look at the average of these things, and that average in the commercial dose was about 7.9, not everyone lost 7.9%. There were people who lost 15, 18, and there were people who lost 5, and so average comes out to be 7.9. So everything got better with these results. What's in the pipeline? And again, this is at this time I would like to show you this slide which shows the journey of lifestyle. Again, and this is not me saying it from the podium and trying to antagonize what Ali is saying. You do lifestyle, you lose weight. And it's the basis of any weight loss program. But if you go further down, you can see the semaglutide came in and we were closer to surgery. Then tirzepatide came in and we can probably say, we said that probably surgery is going to go away, and it's never going to go away because there are always failures of these. And then the newer molecules which are coming out, they are challenging the surgeons big time because the weight loss is about 30% or more. There are other problems associated, and again, I'm sorry if I don't have time to explain what are the complications of surgery and what are the complications of oral and what are not the complications of lifestyle modification, but we need to realize the newer class of medication, which includes the GLP-1s with different combination and a completely different model in which you don't even lose muscle mass, and you still lose 30% of the weight. Would you be going for that, or would you be going for any injectables that you would want to go? So I think strategies for initiating any treatment is how you would want to, you need to look at the cost, you need long-term complication, whatnot. I would like to finish with a final thought, and I think this is very, 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 very important. And I think this will come in the surgical concept, and I think it will already been discussed in the lifestyle modification is what is most important thing in weight loss management? Thank you. Thank you. Because people who treat obesity know that maintaining weight is the most difficult, and which is the biggest pitfall that all of us do, including myself. Thank you, Umar. We give GLP-1 in a hope that they will take it for the rest of their life. People lose weight. Once they lose weight, they stop and they start going to the khabas again. One of my friends was telling me yesterday, he is going to eat double amount of sweets the next 1 week because he's going to start GLP-1 in next 1 week time. And person who's laughing the most is the person. So you could tell the people do this. So zigzag, and this is human nature. And I think that's where I think the final thought is combination therapy. Please don't judge the treatment for oral weight loss medication based on the fact, you know what, people stop, they gain weight, or there is a plateau at the end of the tunnel, and then the people don't do. There's a plateau after surgery. There's the regain after surgery. Their muscle mass loss with surgery. There is everything is, and not everyone is candidate. There are about 5% people who fail. So in a population of about 150 million people, and if you take 5% of failure rate of GLP-1, that is about 7 lakh or 10 lakh people who need bariatric surgery, even if they use GLP-1. So surgery is here to stay, but for a limited people. Lifestyle modification is ideal, but who does it? Ultimately, you come up with negotiating with the patient. You want to be on oral or a GLP-1 if you want to. We never talked about it. That's why all of a sudden it's become a problem now to talk about because you know what, oh, it's an easy way out. The problem is, if you have high blood pressure, which is the best treatment? Lifestyle. Why do you prescribe blood pressure medication? You should say, there should be debate on hypertension and treatment with lifestyle versus oral medication. You just write it because now there is an effective treatment. You treat it, people get better. You do lifestyle, they maintain. You reduce the dose of the oral hypertensive, and you're fine. I think that should be the concept of treating the medication as well. So all these medication, not should only GLP, and this is my biggest debate, and I know Umar sometimes agrees with it, sometimes he doesn't agree with it. I believe in never giving GLP-1 alone. I would give GLP with something, so once they stop GLP-1, we have some background, and then we continue. Strangest thing is, I know industry friends are here as well. I'm not sure why hasn't anyone focused on other medication that you could stop GLP-1, because no matter what you say, 60%? Aisha was, I think, telling me. Someone was telling me yesterday that even in US, the first year, I don't know, I'm sorry, Aisha was, first year stopping of GLP in the first year is, I think, 60%. So again, how would you stop people from not stopping? People will stop. So we need to continue on some medication so they don't regain it. These medications are not super good. They were 5-6%. The only thing they will do is not let you gain weight again. They will maintain weight, and that's how you will you'll have the diabetes in remission. And probably that's the best way to keep the diabetes in remission. Hit, maintain, and maintain for as long as you could do. So I think the add-on treatments are very important, and that's something that we need to think of. And then we can, at the end of the day, take-home messages. Please realize obesity is a chronic disease. It's not a six-pack Shah Rukh Khan problem. This is actually a disease that you need to treat. Stop treating it as an aesthetic problem. It's the mother of all diseases. We never talked. I never gave a talk on this because I never had an option. The lifestyle was the only one and the surgery was the other, and I do neither. So I said, "Ki baat hi karne ka fayda nahi hai." But now all of a sudden I have a reason to say. Now I have a reason to say. At the end of the day, this is not a weight loss. The benefits of a weight loss are huge. Medication pose a lot of problems, and at the end of the day, you need to weigh the pros and cons of it. And at this time, outstandingly, the balance of treatment is, no matter how many people, if Ali comes in and says, you know what, it causes eye problems, and again my surgical colleagues come in, they call muscle weight. Now I can pretty much defend that based on the fact that there's ways to do it, and the newer medication are going to change that scene as well. With that, I thank you all for your attention, and again, thank you.
थैंक यू सो मच डॉक्टर बास। अब तो बात चेंज हो गई है, 64 लाख से अब 15% पर आ गए हम लोग। ठीक है, तो आप लोग के अपने जेन में पॉइंट्स रखें, हम आखिर में दोबारा वोटिंग करेंगे। नाउ वी हैव अ थर्ड कार्ड टू डिस्प्ले एंड दैट्स प्रोफेसर डॉक्टर मोहम्मद जरीन। ही इज़ अ bariatric surgeon well known from KP. Sir, please come on stage and defend the bariatric surgery now.
Bismillah ar-Rahman ar-Rahim. Thank you so much. I'm extremely thankful to Pakistan Endocrine Society, and it's a great privilege and honor for me to be here amongst the galaxy of physicians and endocrinologists from across the country and abroad. This topic of obesity and its treatment is, as everybody discussed, that obesity is a problem and it's a mother of all problems, as said by Dr. Raza. Remission of type 2 diabetes after bariatric surgery is a fact or it's a fiction, and there will be debate soon after this talk. I think so. Bariatric surgery or weight loss or metabolic surgery is a variety of surgical procedures on obese patients. It's done either by reducing the size and capacity of the stomach or resecting and rerouting the small intestine to a small gastric pouch. Depends upon which procedure we are choosing for the patient. Diabetes, everybody knows that it's a chronic metabolic disorder characterized by persistent hyperglycemia, either by impaired insulin secretion, insulin resistance, or both are mechanisms are involved. With appropriate treatment, medical management, and or surgical management, remission of type 2 diabetes mellitus is achievable in selected patients, not in every patient. These slides are not for educated and learned endocrinologists, for my less educated people like myself. Everybody is talking about remission, partial remission, complete remission, and prolonged remission. Partial remission, when the glycemic indices, they fall in the category of pre-diabetic status, like HbA1c of less than 5.7 to 6.4. and fasting plasma glucose level of like 100 or 125 milligram %, and these indices, they stay for like minimum of 1 year. Complete remission means the glycemic indices, they remain within the normal range and they stay for 1 year, and when the complete remission stays for more than 5 years, that means prolonged remission. When it comes to treatment of diabetes in obese patients, so as started by Professor Raza, Ali and then Professor Raza, that lifestyle modification, regular exercises, medications, and ultimately surgical intervention. So the previous two modalities of treatment, they provide like short-term and non-durable weight loss, and so poor glycemic control. But surgery in indicated patients would provide a sustainable weight loss, and thus hyperglycemia can be well controlled. So what happens in obese patients? Why there is diabetes in obese patients? So many mechanisms are involved, like this: insulin resistance, inflammation of the beta cells of pancreas caused by lipotoxicity, and both these mechanisms can lead to hyperglycemia. After bariatric surgery, what happens? The glucose homeostasis, it is improved, insulin sensitivity is increased, and adiponectin levels is increased. What research says? This is a meta-analysis of more than 600 studies, and this study was conducted between 1990 and 2005, and this study was published in American Journal of Medicine in 2009. And this is about bariatric surgery is a treatment modality for remission of diabetes. And the results show that almost more than 80% of the patients, they sustained prolonged diabetes remission after bariatric surgery. Similarly, there's another meta-analysis. It was published in JAMA. And one of the RCT in that meta-analysis showed that the results and diabetes remission after bypass surgery, it was almost more than 90%. But one of the studies shows that sleeve gastrectomy has got lower results as compared to bypass procedures. We are talking about multimodality treatment, and the last slide shown by Dr. Raza was also about this, that medications and injections, they are not competitors for surgery, rather they are adjunct, and they are helpful, and the combination treatment modalities would provide better results. So this study about that it's another RCT which shows that combination of surgery along with the medication would provide better results as compared to only extensive medical therapy. Almost similar results. The efficacy of any treatment modality will be judged by long-term, and if it can be assessed by long-term follow-up. This study has shown that follow-up after 6 years and follow-up after 15 years of bariatric surgery and metabolic surgery for obese patients having diabetes mellitus. So the remission was noticed of almost in more than 60% of the patients after 6 years of follow-up, and 15 years follow-up showed that more than 30% of the patients, they had complete remission of diabetes after metabolic surgery. Briefly about procedures, what we do in bariatric surgery and metabolic surgery, right? Previously, there used to be adjustable gastric banding, which is almost obsolete now. Currently, these procedures commonly performed at vertical sleeve gastrectomy, one anastomosis gastric bypass, Roux-en-Y gastric bypass, and then there are certain other procedures which are known as quite stronger and extensive procedures like SARDS and SACS. Briefly, like in gastric banding, we used to apply an adjustable band around the proximal part of the stomach just to divide the proximal smaller chamber and distal bigger chamber. And there was a controlled and slow release of food contents from the proximal chamber to the distal chamber as it was done by the gastric banding. And this sustained release and slow release of nutrients from the stomach, it was helpful in weight reduction as well as in diabetes control. Vertical sleeve gastrectomy is the most commonly performed procedure throughout the world in bariatric surgery, in which normally our stomach has got a capacity of like 1000 to 1500 ml. So in this procedure, we remove pretty good chunk of the stomach based on greater curvature, and the majority of the stomach portion is removed, and the capacity is reduced almost 100 to 90 cc. And the stomach is transformed into a banana-shaped structure. The caliber is reduced to almost 2 to 3 centimeters. There's another commonly performed, and this very popular as far as metabolic surgery in diabetes control is concerned, Roux-en-Y gastric bypass, in which a pouch of the stomach is created from the proximal stomach, which the capacity of which is hardly about 30 to 40 cc. And then that pouch of the stomach and the rest of the stomach is resting inside the abdomen, is performing its rest of the function, but it's detached from the alimentary tract. And the small pouch of the stomach is then anastomosed to the jejunum in a Roux-en-Y fashion. So there are two routes are created. One is for alimentary and the other one is for biliopancreatic juices. Basically, the concept of metabolic surgery is based on like either we reduce the size of the stomach and we restrict the food intake, or we create certain procedures in which absorption is decreased, and they are known as hypoabsorptive. and the other one is known as restrictive procedure. Sleeve gastrectomy is totally a restrictive procedure. The capacity is decreased and there is no alteration in the continuity of the intestine. But in these bypass procedures, what we do, we just change the route of the food, and that's because we want to cause hypoabsorption or malabsorption. One anastomotic gastric bypass, long 15 to 20 centimeter pouch of the stomach is created based on lesser curvature side, and rest of the stomach again is lying inside the abdomen, and it's in continuity with the duodenum, and the pouch of the pouch created of the stomach is anastomosed to the jejunum at least 150 to 200 centimeters from the ileocecal junction. So the food is directly entering from the pouch of the stomach into the small intestine, and almost 150 to 200 centimeters of the stomach of the small intestine is bypassed. It's mainly hypoabsorptive or malabsorptive procedure. Biliopancreatic diversion techniques are indicated for a very limited number of patients, patients with super obesity with a BMI more than 60, patients with previous failed procedures like gastric bypass or banding or sleeve gastrectomies, or there's some other indications for this procedure. In this procedure, a sleeve is created and then the stomach is disconnected from the duodenum at the D1 level. And then the D1 level is anastomosed to the ileum almost 300 centimeters proximal to ileocecal junction. So rest of the almost half to 1/3 of the small intestine is bypassed. So this is considered to be the most strongest procedure as far as weight loss is concerned, and it can cause up to 70 to 80% of the excess weight loss. How metabolic surgery can cause remission or control of diabetes. There are different mechanisms are involved. It's not about the downsizing the capacity of the stomach. It's not about restricting the food intake. It's about modulation of different hormonal mechanisms. So one theory is incretin hypothesis, the gut-brain axis, then there's foregut hypothesis and rapid higher gun delivery, and then there's other mechanisms. Either in combination they work together and they can cause weight reduction and ultimately glycemic control. So this slide is like, okay, everybody, I need not to discuss about how GLP-1 is secreted and how does it work. There are certain hormones which are released from the duodenum and proximal jejunum. They are known as anti-incretins, and they are released as a response of food entry from the stomach into the small intestine. And their effect is like they are against the function of GLP and GIP. So what happens in bariatric surgery? Normally in the sleeve gastrectomy or in bypass, especially in Roux-en-Y gastric bypass, the whole length of the stomach, the proximal, the duodenum and the proximal jejunum is bypassed. So there's no food entry into the duodenum. Anti-incretin levels are decreased, and there is rapid entry of food nutrients from the stomach into the small intestine. So there is increased secretion of GIP and GLP. So anti-incretins are decreased and incretins levels are increased. So obviously insulin level goes up and glycemic control is achieved. And interestingly, this was a debate that there's a question asked that how much time does it take to control diabetes after bariatric surgery. So soon after the bariatric surgery is performed, especially in bypasses like Roux-en-Y gastric bypass or one anastomosis gastric bypass, the glycemic indices, they start reducing soon after the surgery is performed. I mean, within first week or second week of surgery. And the mechanism is the same because there's no food entry into the small intestine, and incretin levels are increased and anti-incretin levels are decreased. Even the patient has not yet lost his or her weight. It was discussed that it's not about downsizing and it's not about reducing the capacity of the stomach. Certain hormones, they are responsible for either weight reduction, and there are some other hormones which not only act locally on the intestine and cause glucose homeostasis, there's one hormone which is released from the fundus of the stomach, and that is ghrelin. Ghrelin acts on the brain, increases appetite, and that's how the food intake is increased. So after bariatric surgery, either totally the fundus of the stomach is removed, as happens in sleeve gastrectomy, we just remove it from the body, or it is eliminated from the alimentary tract and food entry into this, the fundus is not there. So automatically ghrelin levels are decreased, and is a rapid influx of the food into the small intestine. There are some other hormones which are known as anorexigenic hormone, they are PYY and PYY36, they are also released. So in combination of these hormones acting on your brain, appetite is decreased, food intake is decreased, absorption is decreased, and thus weight reduction happens, and ultimately glycemic control is achieved. Almost the same mechanism that the gut is not available for food entry, proximal gut, especially duodenum and the jejunum, and the hormonal balance is reversed. It's another question that, okay, in bypass procedure, we do bypass this duodenum and the jejunum, but what happens after sleeve gastrectomy, and how this hormonal modulation happens after sleeve gastrectomy? So the answer is that in sleeve gastrectomy, we just change the capacity of the stomach, and we just transform the stomach. So the stomach capacity is reduced, the transit time is decreased, there's rapid influx of the food nutrients from the stomach into the intestine. And that's how all these hormonal mechanisms, they are reversed, and so the anti-insulin hormones are decreased, and the pro-insulinogenic hormones are increased. Okay, this morning, somebody was asking about that, what are the patients who are candidate for bariatric surgery and others are not? So patient selection is important. Every obese patient is not a candidate for bariatric and metabolic surgery, and every diabetic patient is not a indication for bariatric surgery. सोशल मीडिया पे हम सुनते हैं कि भाई पता नहीं क्या 90 मिनट्स में शुगर कंट्रोल, शुगर का खात्मा सारी, और मेरे ख्याल में किसी ने अच्छी टॉक की कि भी शुगर का खात्मा नहीं होता है, रिमिशन होती है. So there are certain predictors which patients will benefit from this procedure and others will not. So there are 3 different predictors which can make you decide whether the patients are good candidates for bariatric surgery as far as diabetes remission is concerned, and others, they will not benefit at all, and they will just face the complications of this extensive procedures. So this is a diagram scoring system. There are 4 parameters are used, and the patients, they are scored according to the parameters and variables like age, HbA1c, oral hypoglycemics, and insulin use. And the higher the score, lesser are the chances of diabetes remission and control, and lesser the score will have more chances of diabetes remission. Similarly, there's another ABCD, again 4 variables in this scoring system: age, BMI, C-peptide, and duration of diabetes. So the scoring, higher the score of the patients will predict that there will be higher chances of diabetic remission after metabolic surgery, and lesser the scoring will have less chances of diabetes remission. There's another predictor in which the patients are classified into mild, moderate, and severe groups based on variables like pre-operative number of anti-diabetic medications, pre-op insulin use, pre-op duration of diabetes for years, and pre-op glycemic control in terms of like HbA1c. So mild and moderate groups of the patients are the ones that can benefit from metabolic surgery, and severe groups of patients, they will not benefit from any kind of metabolic surgery. Again, there was 2 studies conducted in which 2 procedures were used, like sleeve gastrectomy and Roux-en-Y gastric bypass. So the mild group of patients, they had pretty good results in terms of diabetic control. In one of these studies, that more than 90% in bypass procedures and more than 70% in sleeve gastrectomy. And in another study, similar results were noticed. And but in moderate group, the sleeve gastrectomy has got much lower results as compared to bypass procedures. And in severe group of patients, none of these procedures will work. Less than 15% chances of diabetes remission. Okay, very commonly asked question by the patients and their relatives when they come to bariatric clinic. डॉक्टर साहब complication तो कोई नहीं है इसका, कोई साइड इफेक्ट्स तो नहीं इस ऑपरेशन का. तो मैं कहता हूँ कि साइड इफेक्ट तो पानी पीने का भी होता है. एंड सर्जिकल प्रोसीजर दे डू कैरी अ लॉट ऑफ साइड इफेक्ट्स. और अगेन सोशल मीडिया कैंपेन ये होता है कि भाई कोई कॉम्प्लिकेशन नहीं है, लेप्रोस्कोपिक होता है तो कोई कॉम्प्लिकेशन नहीं है. ठीक है, अगेन आई थिंक इट्स अगेंस्ट द एथिक्स एंड रूल्स. Long term complications of bariatric surgery like they can happen like incisional hernias. Obviously it's done either robotically or laparoscopically. Chances of incisional hernia are much lower as compared to open surgery, but still there are chances of port side hernias, internal herniations, intra-abdominal adhesions, anastomotic structures. As we change and modify the continuity of the intestine, we reroute it and we re-anastomose it. And their chances of structure, especially after bypass procedure, they are quite common. Even in sleeve gastrectomies, when we don't care about the proper application of staplers, and especially by applying the first stapler quite near incisura of the stomach, if we stay close to it, there are chances of structure and narrowing is there. For no reason, I don't know, but there are chances of biliary and as well as kidney stone formation quite high after weight loss, not after bariatric surgery, but every kind of weight loss can predispose to stones formation. Nutrition deficiencies are more common, and especially in bypasses, and the ones which I mentioned about like SARDI procedure and SASI procedures. Psychiatric complications. Okay, so summary is that bariatric procedures, metabolic surgery can have long-term and sustainable glycemic control results if the patients are properly chosen for and they are properly selected and predictors are assessed prior to surgery. And one thing, as I mentioned, it's not competition between the medical treatment of obesity and between the medical surgical treatment of obesity. Personally, I think that both these modalities, they can help the patients in combination also. And my practice and post-op patients who just fail to respond to surgical as far as weight loss is concerned, or their chances of weight regain. So GLP-1 analogs, they can have effective treatment after bariatric surgery as compared to without bariatric surgery. So bariatric surgery is one of the treatment modality, and it can provide better glycemic remission control if the patients are properly chosen. Thank you so much once again.
Thank you so much all. I would like to thank Dr. Yaqub for choosing so smart speakers. सबका BMI normal था, तो आप लोग उनको भी idolize कर सकते हैं. Before going to the rebuttal, I want to take comments from the senior faculty or any questions from the audience. Mic आपको दे देते हैं sir.
For Abbas. Abbas है?
Dr. Abbas.
Oh, so yeah, Abbas is here.
ठीक है.
Abbas question जो है वो ये है कि debate remission पे है, and remission by definition is HbA1c less than 6.5% and no medicine for at least 3 months, and this is now accepted. And your debate was on, of course, leaders and then to maintain it. So by definition वो remission तो नहीं होगी. So how will you defend that?
अब ये सिर्फ उमर सवाल पूछ सकता था, और मैं आपको ये सच बता हूँ, इसने सवाल पूछने से मुझे कल इसका जवाब भी दिया था. इसने कहा था कि डायबिटीज प्रिवेंशन ट्रायल्स में जब आप मेटफॉर्मिन इस्तेमाल कर रहे होते हैं, और तो फिर आप डायबिटीज प्रिवेंशन ट्रायल किस तरह कर रहे होते हैं जब आप मेटफॉर्मिन ले रहे होते हैं. तो इसने जान के पूछा था ताकि मेरे को स्कोर बढ़ जाए, क्योंकि पता था कि मेरे सबसे कम वोट होंगे. तो इसके सवाल का जवाब भी यही है कि व्हेन यू टॉकिंग अबाउट प्रिवेंशन, यू आर लुकिंग एट द A1C व्हिच इज लेस एंड यू आर मेंटेनिंग योर वेट. एंड आई एम नॉट सेइंग कि उसके लिए आप दवाई दो. यू कैन lose 15% of your weight and then maintain it with something else. Again, Osama kidhar? Osama is the biggest supporter of lifestyle and maintaining the weight. जिस बंदे ने आज तक अभी 50 पाउंड से वजन बढ़ाया ही नहीं है, वो मुझे किस तरह बताएगा कि वो वेट करने के में? पहले मुझे ये बताओ। इसका हाथ मैंने खड़ा देखा था, मैं बहुत जला था। मैंने कहा जो बंदा कल मुझसे ज्यादा खा के मुझसे आधे वजन के ऊपर है, ये लाइफस्टाइल पे कहां से आ सकता है? So again, I think lifestyle is for those, as someone who is difficult to lay. Then again, remission, I take your point. But DPP, diabetes prevention trial, they were on metformin, they were on pioglitazone. So you are treating them, but again, you're trying to get the point across. I hope I answered your question.
So my name is Dr. Abbas from Karachi. I have 3 points from the 3 speakers. First from Dr. Zareen. Sir, in 1928, bariatric surgeon like La Berry introduced the GLP. So it's a big time, I mean more than 70, 80 years, why this GLP molecule has been forgotten, and now why everybody is talking about the GLP. This is the one, maybe some threats for the bariatric surgeon in that time, so they didn't introduce the GLP. My second point from Sir Abbas, sir, you said that 15% weight loss, this is the rapidly weight loss, and you also mentioned some like Bima Guru Map and amylin group. After these molecules, you maybe reduce your 30 to 35% weight reduction. So suddenly weight reduction, is this good for the health? My second last point from Dr. Ali, he said कि 6.4 64 लाख जो लोग हैं हम उसको रिमिशन में ला सकते हैं. तो जो 2 करोड़ सर प्री डायबिटिक पेशेंट्स हैं, तो क्या पहले हम उनको डायबिटीज़ में जाने दें, फिर उसको जो ना वापस जो ना रिमिशन में लेकर आ जाए? सो डिड यू थिंक अबाउट दोज पेशेंट्स? थैंक यू सर.
आपने मेरे मुंह की बात छीन ली कि हमें प्रिवेंशन उससे पहले शुरू करनी चाहिए, लेकिन आप सोचें लाइफस्टाइल जो बास ने कहा है, इट्स वेरी एक्सपेंसिव, सिर्फ अंडे की हद तक नहीं. अच्छा खाना, आप तसव्वुर करें कि आपको हेल्दी खाना खाना है, अभी आप बफे लगेगा ना, अब ढूंढ लीजिएगा कहाँ मिलता है आपको हेल्दी खाना. अनहेल्दी खाना सस्ता होता है, हेल्दी खाना महंगा होता है. क्यों? क्योंकि आपने फूड प्रिजर्व करने के लिए ऑयल, सॉल्ट, शुगर और चीज़ें ऐड की होती हैं, विच एड्स टू द कैलोरीज विच मेक्स इट अनहेल्दी. तो ये लाइफस्टाइल एक तो महंगा है, और ये चीज़ जो मुझे बड़ा नाम जब मैंने देखा प्रोफेसर लीन एंड प्रोफेसर टेलर, मैंने कहा ये मिली भगत है, वो लीन करते हैं और वो नए कपड़े बना के देते हैं उनको. तो प्रोफेसर लीन और प्रोफेसर टेलर की जो है उसमें उन्होंने कहा जो सबसे बड़ा चैलेंज है वो ये है बायोलॉजी एंड द फूड एनवायरनमेंट, दोबारा खींच के आपको ले जाता है. आप क्या करेंगे? देखें बट कढ़ाई आपके सामने है, शनमारी कढ़ाई है, आप जाके देखें मैकडोनल्ड्स है, हार्डी है, कब तक रेजिस्ट करेंगे? अपने फैमिली रिलेशनशिप को बचाएंगे? बच्चों को कहेंगे नहीं भी मुझे चाय और पापड़ ला के दो, मैं तो वही खाऊंगा. आप प्रोटीन कि आप कहें जी कि मैं 2 अंडे खाऊंगा, लेकिन यार क्या हो गया, तुम क्या पैसे खत्म हो गए हैं तुम्हारे पास? कोई अच्छी चीज़ खाओ. हमारा माइंड एटीट्यूड्स टुवर्ड हेल्थ इज, तो हेल्थी लाइफस्टाइल इज वेरी एक्सपेंसिव. अगर आप 64 लाख की बात करते हैं, आप बाकी लोगों को भी, क्या आपके पास पार्क हैं जहाँ खवातीन वॉक कर सके सेफली एट नाइट? क्या आपकी सड़कों के फुटपाथ हैं जहाँ पे आप वॉक करें बजाय गाड़ी भी आखिरी जगह तक जाके बिल्कुल सामने खड़ी करें? क्या आपके पास ऐसे फूड के आउटलेट्स हैं जो हेल्दी खाना दें, जो पेरिशेबल ना हो कि अगर आपने आधे घंटे में ना खाया तो खराब हो जाए? तो ये अभी उनके बाकी सवालात पहले हो जाएं.
अच्छा, okay.
अब अब्बास, या मैं आपको पहले आंसर करता हूँ सवाल? अच्छा,
It's not an answer, it's actually a comment. So I'm sorry I missed your presentation. But just to kind of let you know that we have done this lifestyle intervention trial in Pakistan. And I don't know if it was mentioned in the presentation. So we have conducted this study in 2,000 participants in urban areas of Karachi, Pakistan. And we have proven that you can reduce, you can put diabetes in remission by just lifestyle intervention. We did not use any metformin. It was with the help of International Diabetes Federation, grant. And the answer was that in 60% of the individuals, we actually put diabetes in remission. So these were patients, these were the participants who were at high risk to develop diabetes. We performed the oral glucose tolerance test in these individuals. हमने 3 steps में किया था. हमने first में जो है वो diabetes risk scoring system use किया था, जिसमें we kind of took participants who had high risk to develop diabetes, and then we performed OGTT in those individuals. And after OGTT, the third step was to provide lifestyle intervention. So there was a placebo group and there was a lifestyle intervention group. And even in placebo group, we found out that we prevented diabetes. Can somebody tell me why? जी, this is a very important point. So जब आप लोगों के पास जाते हैं और आप उनको कोई भी कोई चीज़ नहीं देते हैं, they are in the placebo group in the clinical trial, लेकिन आप उनको attention दे रहे हैं, you know कि आप हैं, आप part of the study हैं, this makes a lot of impact on their behavior, on their lifestyle. So even in placebo we achieved, you know, कि diabetes remit उनमें भी हुई, लेकिन there was a, you know, major difference in lifestyle group, intervention group and the placebo. Thank you.
Thank you. Dr. Zareen wants to answer the question.
सर मुझे आप क्वेश्चन समझ नहीं आई.
1928 जो ना ली बारा, he was the bariatric surgeon. He was the first person who introduced the GLP during surgery जो ना. तो इतना अरसा जो ना उन्होंने GLP को मतलब हाईलाइट क्यों नहीं किया था? 70-80 साल से जो ना इस पे कोई काम नहीं हुआ. So अब suddenly everybody is talking about the GLP जो ना. So is there any pressure from somewhere?
Sorry.
सो जो GLP का कॉन्सेप्ट था ये 1960-70s में आया था, जब शो किया गया था कि जब आप इंट्रावीनस ग्लूकोज देते हैं सेम अमाउंट तो इंसुलिन प्रोडक्शन लेस है एज कम्पेयर टू जब आप वही अमाउंट ऑर्डर देते हैं. सो तो कॉन्सेप्ट ये था कि कुछ हार्मोन जो हैं वो गट के ज़रिए से बन रहे हैं जो कि इंसुलिन को स्टिमुलेट करते हैं. 80s में इस पे वर्कअप होना शुरू हुआ. इनिशियली जो है वो GIP पे फोकस किया गया और फिर जो मेन बंदे थे उन्होंने कहा कि नहीं जो GLP-1 है दैट उसमें ज़्यादा पोटेंशियल है. सो इसलिए GLP-1 को फार्मास्यूटिकल कंपनीज ने पिकअप किया और उस पे पहले 2007-8 तक जो है ना वो स्टडीज़ या कमर्शली अवेलेबल हो गया बाय द नेम ऑफ एक्जिनाटाइड जो पहली आई थी. और फिर उसके बाद जो डुअल कॉम्बिनेशन है विद GIP उसका भी डाटा आना शुरू हो गया तो फिर डुअल और ट्रिपल कॉम्बिनेशन आ गई है. सो एंड दैट्स सो फॉर एग्जांपल SGLT2 इनहिबिटर्स. अब जो ये कॉन्सेप्ट है कि जी जो फेरोजीन है ये 1870s में पता था कि जी फेरोजीन से आपको ग्लाइकोसूरिया होता है. बाय 1950s उन्होंने वो कंपाउंड आइडेंटिफाई किया. 80s 90s में जो है उसको मॉडिफाई किया और 2000 में अबाउट 2008-9 में फेज़ 2 फेज़ 3 ट्रायल्स आए एंड 2013 में इट्स लॉन्च. सो दिस इज हाउ लॉन्ग इट टेक फॉर अ ड्रग टू कम. सो दैट्स
Thank you, sir.
Thank you so much. डॉक्टर अब्बास आप आंसर करना चाहेंगे 15% वेट लॉस का? ठीक है सही. एनी अदर कमेंट और क्वेश्चन?
Well,
रिबटल ठीक है.
okay.
आप क्वेश्चन पूछ लेते फिर हम रिबटल शुरू कर
Okay.
लेंगे.
Comments just following your question again. Shahab, probably don't know me, most of you. I'm just moving from England. I've been there working there since my first time and I really enjoyed it. Pakistan Endocrine Society. I've been with exenatide since 2005 and it was first launched, exenatide, as somebody mentioned, by Yata. Every taxi driver was on it to avoid insulin because of DVLA, the driving rules. And we found the side effect, which is the weight loss. And since then, it's earlier somebody mentioned, then the pharma company took over. Then comes the liraglutide, dulaglutide, and finally semaglutide and tirzepatide, and the fifth one is coming, Dr. Abbas mentioned. So this is how it comes, and now we are using it. My question is quickly, or maybe comments. I've been waiting for the last 2.5 days, but the slide comes from the surgeon Dr. Zareen presented. It's about the brain, the gut connection, which is the whole world is now working on that. Okay, it's working again. The world is now working towards psychology of the brain, how things works, your brainstem, which is our food center, and our hypothalamus, which is the food center, mainly then in conjunction with the brainstem, the ventromedial nucleus, and then the arcuate nucleus, all those, the frontal lobe, the reward center, all those things. So just like somebody mentioned the first day, pen is blessing, I think, coming from Dr. H. Amer. We treat bone with a bone pen treat with a different painkiller, tummy pen, different tubular pen, colicky pen. Everything has its own anti-inflammatory pen, all those. How those signals goes to the brain, which was in Dr. Zareen's slide, you have to block it to go up there, the reward center, especially the frontal lobe, which again the culture, the habits and all those things. There comes the GLP-1 analog. Actually, that's where all those signals. Dr. Mathiula talking about the neuronal pain, the myoglobin and all those things. So it's all about that these days, that you block the things so you don't, your reward center is not working, you're not hungry, it's not asking you, the cultural habits, the frontal lobe, and all those things. I think there is a hadith about it. I forgot, I don't want to mention it as a wrong reference or something. But these are the things that the world is now going on. So, a psychology, we have a psychologist there with the dietary thing, and after Michael Mosley book, 8 weeks blood sugar diet, which was first released from Newcastle, and everything started from there. And now, the diet psychology, the teaspoon full of sugar business, so which the patient understand very well. So I would appreciate, next time you bring somebody with a psychology about that, and it will work. Thanks a lot.
Sure. Thank you so much. Thank you. Now the time for rebuttal, a short rebuttal. We have a time limitation, please. We can start rebuttal. Dr. Ali, if you want to come and defend any point against you.
I think specific reason to take sides. It all depends on the context, the place you are, what resources your people have. In urban cities, the strategy would be different. In rural areas, the strategy would be different. Apart from the patient selection, the socio-economic things matter as well. People may be using GLP-1 and analogs indiscriminately, and that is also harming them. The fact is that other than prescribing them, the fact that they need to do strength training, happen of protein in the diet is an important aspect which we cannot neglect. As a nation, although our protein intake is way more than India, 90% of people in India, according to one research, are protein deficient in their diet. We are slightly better off, but we should not be sitting on our laurels and waiting for that. So if GLP-1 is prescribed, it has to be taken with a pinch of salt. We need to make sure that the patient understands they need to have enough protein to counteract the muscle loss. Number two, the strength training. When somebody says exercise, walk, and then straightly gym, nothing in between. Can you do strength training at home? Yes. Do you have to go to a gym? Not necessarily. Going to gym alone doesn't solve the problem, because there are specific exercises that are more suitable than not just bodybuilding, and other people just assume that you are just making your pectoral muscle stronger will make you a better and a much more, better diabetic control patients. So that's what my rebuttal would be. As far as surgery is concerned, surgery itself may be safe, but although there are complications, everybody knows. The post-operative time is the most critical time when they need help, and the help is usually not available. They need a qualified nutritionist who can manage their nutritional deficiencies. They need a qualified endocrinologist who should be able to manage dumping syndrome and other things that happen all the time. They should be able to look for other things. So there is that big disconnect in bariatric surgery if they are not being managed in a big center in which all these resources along with psychological care. Many a times in America that I remember that you need to have mandatory psychological screening before you go for bariatric surgery, because people may have a body image problem. They may have underlying bulimia, which remains undiagnosed and gets aggravated after surgery. So my rebuttal is lifestyle. I don't claim it to be a panacea, an answer for all things. But even if you do choose GLP-1, it has to be with a couple of very robust safeguards for the patient, whether it comes from the doctor, from the community, from the support staff. That's our responsibility as well, because the first thing is do no harm.
Thank you so much. Dr. Abbas, a short rebuttal.
Saeed ने मुझे एक दफ़ा बड़ी अच्छी बात बताई थी, and my rebuttal will start and stop there. He told me, we were having an argument, and he told me that deodorants are in addition to shower, not instead of shower. So these lifestyle modifications, surgeries are in addition to medications that you can use. But I think personally, the most feasible and easily achievable lifestyle change that you can make and then probably lose and get the reward and then maintain it through some way is through the medication. So that will be my rebuttal. I'm not saying lifestyle is not important. I'm not saying surgery might be needed in few people, which I agree. But I think the medications are they're usually not something that, again, I think the medications are the cornerstone for treatment. And I think किसी को झूठ नहीं बोलना चाहिए, सबको सच बोलना चाहिए. Ideally, it's perfect. Lifestyle सबको करना चाहिए घर में. But don't we know that everyone speaks a lie once in a lifetime? So I think we need to realize that you need to be building your bridges and making sure that you do whatever needs to be done. So again, instead, not in addition.
Thank you so much. Dr. Zareen, a short rebuttal from your side.
मेरे पास जब पेशेंट्स आते हैं, स्पेशली दोज हु आर विलिंग फॉर लाइक अ वॉक इन ऑपरेशन, तो मैं उनसे बात कर देता हूँ कि भाई जब छत पे चढ़ेंगे तो सीढ़ियों से जाएंगे, छलांग लगाएंगे तो नीचे गिरेंगे. I mean, lifestyle modification is the first step to work on. Then medications and ultimately surgery. तो उसमें फिल्टर आउट हो जाते हैं. और मैं डॉक्टर अली साहब से बहुत वो करता हूँ कि मल्टी मॉडरेटरी ट्रीटमेंट जो है ना, MDT इज़ वेरी मच इंपॉर्टेंट, जिसमें सब स्पेशलिटीज़ का इन्वॉल्व होना बहुत ज़्यादा ज़रूरी. अदरवाइज द रिजल्ट्स विल नॉट बी दैट प्रॉमिसिंग. थैंक यू सो मच.
थैंक यू सो मच. नाउ उसके बाद आपकी कमेंट्स. अच्छा, लास्ट पे वोटिंग करते हैं. इट वाज 5, 10 एंड 15. सो लाइफस्टाइल मॉडिफिकेशन. सर आपके तो ज्यादा हो गए सर. ओके, मेडिसिन नीडल. सर आपके कम है. डिओड्रेंट नहीं यूज करते लोग. अच्छा, एंड बियाटिक सर्जरी. सर वो तो मैं भी उठा लूंगा. ठीक है, थैंक यू सो मच. नाउ द chairperson, please sir, have a short comments on the debate.
Thank you for the asking for the comments. Actually, all three speakers very well known. Everybody knows them, and this is absolutely true that one size don't fits all. So someone who is coming to us for the weight loss or the diabetes management, we usually start with the lifestyle modifications. That depends. If the HbA1c is very high, then not only the lifestyle modification, but maybe the medications will be simultaneously for these patients, and at the end you can cut down the medications and just keep them on the lifestyle modification for the long time. But there are certain patients with very high BMI, and we know that this may not come with the diet and exercise. Then definitely for after some time, definitely we refer them for the consultation or a suggestion from the bariatric surgeons. So I think so all three talks very well presented. Thank you.
Thank you sir. Dr. Jamshed, please.
बिस्मिल्लाहिर्रहमानिर्रहीम. आई थिंक कि ये जो मॉडलिटीज़ हैं, 3 मॉडलिटीज़, एवरी मॉडलिटी इज़ इक्वली इम्पॉर्टेंट. कुछ जो मरीज़ होते हैं, दे आर डिपेंडिंग अपॉन दिस क्राइटेरिया, वो स्ट्रेट फॉरवर्ड दे विल बेनिफिट फॉर bariatric surgery, and there are significant number of the patients who can benefit from lifestyle modification and this injectable therapy. But some patient, there is a gray area in which needs discussion with the patient, and even discussion in a multidisciplinary team who will benefit from which or the combination of which. Here is one important thing, that professionalism comes the first. Here, if the doctors, if we think of the commercial, so they will decide in a wrong way. But if they are thinking commercially, they in a professional way, they can decide the better treatment. Because it is actually not there is not a single and simple question whether bariatric surgery, whether injectable or lifestyle modification. But it is actually the decision that a right mode of treatment for a right person in a right time. Regarding this bariatric surgery, no doubt with the understanding of the knowledge of the diabetes mellitus, this bariatric surgery is no more considered only to be the surgery for the weight loss. It has revolutionized the treatment of the diabetes mellitus in a select of patients, and which has a significant impact on their future and which reduces their complications. So the overall message is they all three carry equal, but it's the right patient, right treatment, and right decision. That's important.
Thank you so much, Dr. Ali.
Thank you very much, Suleman. Very well moderated session. Excellent. And I think wonderful talks by all three speakers. So Suleman was telling us to give comments first, but I told him take the voting first so that we don't get biased with what is there. So I think just one message: obesity is a chronic disease. It's a chronic progressive disease, and the treatment does not lie in 1, 2, 3 years. So of course, when it's a chronic disease, the treatment is also long-term. And once the treatment is long-term, you cannot use one modality just continuing for years and years and years. Of course, lifestyle therapy is the core. It has to be there. Professor Jawa has already shown that and won it. But of course, wherever needed, injections and surgery has to be there because obesity has to be treated. It's a disease causing more than 200 illnesses. And I think wonderfully arranged session. Thank you very much, Yaqub, for putting this debate in the scientific session. Thank you.
Thank you so much. Thank you so much. Thank you. Now the next session is about the Indo bus. So please stay here for the Indo bus. It's for the fellows to encourage them. And the Nizam will take the stage from now and he will be moderating this session. Thank you.